cardiologist and an electrophysiologist who is going to speak on intravenous iron in the management of heart failure. I think we know that there are 4 essential pillars in the management of heart failure, and these are very important adjuvants. Dr. Pillai.
Thank you, sir. Thank you for the kind introduction. Thanks to the JPEF organizers for the privilege. Mine is a relatively simple and straightforward topic. I will keep it short. Iron deficiency anemia in heart failure. Demystifying diagnosis and treatment of iron deficiency. We are all familiar with the 4 pillars of heart failure. This is what we all get fixated on, the beta blockers, the ARNIs, SGLT2s, and so on and so forth. But there is always some lacuna that we are missing, including lifestyle, which Srijit sir was talking about. And another one lacuna that we miss is anemia in heart failure. Data shows that close to 50% of patients with chronic heart failure have anemia, which is treatable, undiagnosed, and untreated. It causes reduction in exercise performance, reduced quality of life, as well as increase in mortality and hospitalizations. When you look at the prevalence, burden, and pathophysiology of iron deficiency anemia, how do we measure iron deficiency? We look at iron levels, ferritin levels, and transferrin levels, and transferrin saturation. The 2 key variables which are most useful is ferritin level as well as transferrin saturation. A ferritin less than 100 is iron deficiency, or a transferrin saturation less than 20%. These are the 2 most useful variables, although serum iron can also be used. Consistent data showing that at least 50% of patients with heart failure have anemia. Why do heart failure patients have iron deficiency? It's multifactorial, including reduced iron absorption due to gut edema, decreased iron bioavailability, as well as increased iron loss. There is hepcidin blockage, which can also prevent iron absorption, as well as oral iron bioavailability. It leads to both erythropoietic as well as extra erythropoietic effects, reduction in hemoglobin and myoglobin, both of them reducing oxygen delivery, oxygen utilization, and leading to poor exercise tolerance. So how do we screen? Guidelines recommend that you screen heart failure patients for at least once or twice a year for iron deficiency anemia. If they have heart failure and hemoglobin which is low, if it is very low hemoglobin, like if it's less than 7 or so, particularly in acute decompensated heart failure, and there is active bleeding and so on, it has to be corrected with the blood transfusion. Otherwise, you look for iron studies, and if the ferritin is less than 100 or transferrin saturation less than 20%, correction of the using IV iron needs to be contemplated. So once or twice a year, heart failure patients needs to be screened. If your hemoglobin in male less than 13 or female less than 12, which is kind of a high threshold, we are usually concerned. We want to keep cardiac patients and heart failure patients' hemoglobin at least more than 10. If it is less than 10, we should be concerned. But generally, I think we all have a very low threshold, high threshold for accepting anemia. We take it for granted that it is anemia of chronic disease. Even hemoglobin of 9, we tend to normally accept, but we may not appreciate the degree of quality of lifestyle compromise the patients might be having due to anemia. So they can be screened, and if the patient have heart failure with EF less than 45%, or acute heart failure hospitalization, or symptomatic recently hospitalized patient at home with an EF of 50%, all these patients would benefit from correcting anemia. 3 months after which their iron levels and hemoglobin levels can be checked, and then on an ongoing basis once in 6 months. Barriers to detecting iron deficiency in these patients, obviously there are additional blood tests in terms of iron studies, and ferritin is always a tricky marker to be following, because ferritin is an acute phase reactant and it can be increased in any acute inflammation. So ferritin levels have to be checked in a chronic state when the patient is not acutely ill from any other medical problems. The 2016 ESC guidelines do recommend screening heart failure patients for anemia. So iron, as we know, can be given as either as oral as well as intravenous therapy. These are the different intravenous therapies which are available, including iron dextran, sucrose, gluconate, carboxymaltose, derisomaltose, and so on. Dextran is the one which has historically been notorious for anaphylactic reaction and so on, and require a test dose. The newer molecules do not require a test dose. They do deliver more amount of iron, as well as there are more data favoring these newer molecules, as well as particularly for heart failure. Oral iron is an alternative, but apparently the oral iron bioavailability is low, and the data does not support repleting oral iron orally for improvement in exercise capacity, partially because the correction is inadequate. Ferric carboxymaltose is a safe form of injection. It's usually given as 2 doses of 750 milligrams separated by 7 days. There are reasonable amount of randomized data supporting the correction of iron deficiency anemia with intravenous iron supplements. These are the different trials: FAIR-HF, CONFIRM-HF, AFFIRM-AHF, studied in heart failure patients with reduced EF as well as mid-range EF, all of which the endpoints have been improved functional capacity, improved symptoms, as well as reduction in hospitalization. These are part of the guidelines. The 2022 AHA guidelines recommend IV iron correction as a 2A recommendation. On the other hand, erythropoietin stimulating agents is a contraindication. It's usually in CKD patients that these are considered. The 2023 ESC heart failure guidelines also suggest IV iron supplementation for heart failure with reduced EF and mid-range EF, class 1 recommendation, IV correction with ferric carboxymaltose and derisomaltose, level of recommendation 2A. Again, ESC 2021 in support of screening of anemia in heart failure patients, EF less than 45 and ferritin less than 100 and transferrin saturation less than 20% as a cutoff for correction. So in summary, IV supplementation is superior to oral supplementation. Close to 1,000 to 2,000 milligrams are given over a 2-week period, which can improve quality of life and functional status, symptomatic benefit, reduce hospitalization. So relevance of screening heart failure patients for anemia at least once in 6 months, checking ferritin and transferrin saturation level, and correction with IV iron for disturbing patients. Thank you.
In patients with JPEF, heart failure, preserved ejection fraction. And the other thing you said, erythropoietin is class 3, but actually nephrologists are using it for their patients with anemia. Of course, they don't raise the hemoglobins very high. You have to be, should not, maybe it should be less than 11. But they use it.
Right. So I think the mechanism of anemia in CKD patients is slightly different. There is bone marrow suppression, in potential bone marrow suppression in CKD patients, wherein erythropoietin supplementation has a role, or I think erythropoietin levels, which to begin with is partly produced from the kidneys, is deficient in CKD patients. Erythropoietin is indicated predominantly for CKD patients with anemia. The guidelines do not particularly talk about heart failure with preserved EF. They do talk about EF less than 45%, as well as EF less than 50% is also mentioned, wherein the mid-range heart failure patients would qualify. But interestingly, at least as far as the guidelines are concerned, they have not mentioned heart failure with preserved EF.
But maybe I think it could be offered because
I think so,
you have
yes.
no other, nothing else to offer.
Right, right.
Cannot do harm. Proceed to the next topic
Thank
if
you.
there are no more questions.